Hi everyone, this is Lillian Stengard, and I'm the Texas System of Care Project Director. I'm very pleased to have the Texas System of Care partnering with the National Building Bridges Initiative and St. Mary's Home for Children for today's webinar. This webinar is the second in a series of webinars provided by the National Building Bridges Initiative to assist Texas residential treatment centers with the implementation of best practices intended to improve long-term outcomes for children and families who receive RTC services. The first webinar was very enthusiastically received and resulted in a rich question and answer session after the presentations. I look forward to today's presentations and question and answer session as well. At the end of this webinar, there will be an evaluation, and while the evaluation is required to receive social work, continuing education credits, I encourage everyone to complete the evaluation, as that will help to inform the planning committee about your training needs and also about your thoughts about this webinar and how we can improve future webinars. To get started today, we have Sherri Hammack, National Coordinator from the National Building Bridges Initiative. Sherri has more than 37 years of experience in health and human services at the federal, state, and community levels, especially in the area of systems transformation. Previously, she was the project director for the Texas System of Care, and I'm very pleased to have her expertise here today. And without further ado, here's Sherri.
Thank you so much, Lillian, and I'm glad to be here and glad to be continuing to work with Texas. Also with us on this webinar, we'll have a leadership team from St. Mary's in Rhode Island, and so we will hear from them, and I know you're looking forward to hearing from them as a program that is on this transformation journey and that has boots on the ground. For starters, I would like to go ahead and pull up my PowerPoint and talk to you a little bit about Building Bridges Initiative with the value of family-driven. And I know that many of you may be singing to the choir, but hopefully there'll be some new strategies and ideas that you can glean from some of this work. So if we can get that first slide pulled up on the PowerPoint, we'll get started. So the word family-driven is something that we use a lot, or we like that term, and it is very positive, but what does it really mean, and what does it mean when you're operationalizing that and putting it into action? So family-driven, just to look at this book definition here, means that families have primary decision-making role in the care of their own children, but also as well as in policies and procedures governing care for children in their community, or whether it be their state, tribe, territory, or nation. So this means that on a personal level with their child, that they have a primary role in decision making, and then hopefully they're brought in as a partner to help guide policies and practices. So this can really include choosing culturally and linguistically competent support services and providers, setting goals, designing and implementing and evaluating programs, monitoring outcomes, and partnering and funding decisions. So those are exactly, like I said, the book definition of what family-driven means. And so for residential practices, why is this important? Because, and I'm going to tell you things that are just not good ideas, that are based and grounded in research that we have found with the Building Bridges Initiative. One of the strongest predictors of post-transition success and after discharge is that 50% of youth who age out will live with some member of their family within a couple of years from discharge, and that the strongest predictor of positive outcomes post-discharge is support from the family. And I think most people can see that, how that works even in their own lives. And so with work with family, work with family issues and on facilitating community involvement while the youth is in residential treatment is also very critical, as research has told us. And so that's sometimes a missing piece, is coordinating that continuum of services and supports in the community with the family. And I know for our work that sometimes, you know, families may not be protective factors in the youth life and for the kiddos that we're serving, or offer a safe or stable nurturing relationship. But really that's the challenge for us, for these children and youth. It's the role of residential providers to develop that vision and the knowledge and skills to really search out and engage and recruit families or other family members, because families can come in different sizes, and really looking at those connections. I know we talked about at the last webinar that for youth-guided care is that we're looking at transition upon admission. So why this is important, again, the effectiveness of services, what research tells us is that the effectiveness of services, no matter what they are or, you know, what type of service they may hinge on, it's really how, when, and why families or caregivers are engaged in the delivery of care. So it's becoming increasingly important that we look at family engagement and work with youth, with family engagement while they're in a residential intervention, and certainly, you know, within the community. So next is knowing that all that's very important. What can residential programs do? And this is, again, based on some of the work that we've done nationally. One of the most important steps is like hiring a family partner or a family partner advocate. And you'll see here the first bullet is perhaps even hiring multiple family partners and not just using a token family that does everything, but hiring family partners that can support each other. We've learned that here in Texas, you know, with our certified family partners being linked to local mental health authorities in the community, and so that would stand to reason. That has served us well. There's a lot of support about peer support specialists and hiring those peers and the value add that they have within, whether it's, you know, state hospitals or local mental health authorities. So this falls in line with that thinking. And so the second bullet really talks about having perhaps a senior family partner as part of the executive team and to provide supervision to those other family partners. And having, you get in this mindset, I think, when you do this work, is that you just, you have family partners as part of all the decisions. They're part of every part of the way that you do business. It's not an afterthought. They're at the beginning helping you plan, implement, and evaluate things in your organization. So another strategy is having family partners share offices with other staff, so they're very embedded and integrated into the system. The other thing that is very helpful is to have family partners serve as co-trainers in staff orientation and ongoing training programs. And that was brought up, I know, in our last webinar with Youth Guided, is that the youth at one particular program, they were talking about how they interview potential staff, and they're also involved in the training, and that the same holds true with families. Families being involved with staff orientation in residential programs and serving to be a part of the hiring process. Families are great assets for being part of evaluation teams and helping to evaluate practices and policies and helping figure out how we can do things better that are more matched with what the family needs. So the motto that we use quite frequently within system of care and certainly in other programs is nothing about us without us. So that if you think about that in those terms, that helps think about who are your go-to people to bring that voice in. So a second most important step would be developing a strategic plan, which I'm sure many of us, many programs and organizations have strategic plans. But if you're looking at really strengthening and retooling and bringing up, family partners and family-guided care, that you can go to the BBI website, and that website link is at the bottom of your, it looks like some folks are getting some audio difficulties, so I'm hoping that can get addressed, and I'm going to continue to go forth, knowing that this is getting recorded and hopefully people can download and fill in the missing gaps. But on this particular slide, the bottom shows the web link. If you go to some of the tools, there's a tool tab on the website, and you can see BBI assessment tool. There's also other great guides. But if you do that prior to a strategic planning process, that can help educate and gain awareness to some ideas about how you can really strengthen the family-driven part of the way that you do business. As part of the strategic plan, you've got to really have the leadership team on board and have them gain some of that background education and awareness. And so there's, as you can see on this, there's family tip sheets that are in the BBI website. There is a book on best practices in residential on that second bullet, and you're able to order that. That's what I really love about that book, is there's a lot of anecdotal program experiences with contact information, so you're able to follow up and contact folks. And if you ever run into someone who's left, you can always contact me or someone at BBI, and I'll have that information at the last slide. Another great tool is the Massachusetts, they have a resource guide called Creating Positive Cultures of Care. There's also one that's housed at the Department of State Health Services in Texas called Creating a Culture of Care, if you Google that. So if folks, leadership team can educate themselves, they can read about that and then go into a strategic planning process and really be ready to engage and strengthen those portions of your organization and your operation. So to ensure that welcoming of and partnering with families, here's some things that you would see if this is coming to pass. You would see on your board and executives focusing on specific areas, if these aren't already in place. Like I said, I feel like in visiting with many of you that many programs are thinking along these lines, but really consider including it in your agency or your organization's strategic plan. You would need that buy-in and commitment from leadership, and you're going to hear from Carlene and her leadership team at St. Mary's that you really have to have the leaders walk the walk and not just talk the talk as far as that transformation for family-driven care, and that there's clear values, that we were really looking at strength-based practices, but also language, that you're having respectful language and you're incorporating trauma-informed care and treatment. Your services and supports are individualized and flexible and family-driven, youth-guided, and have that cultural and linguistic competence. And that we're really integrating community practices into this. So, for example, and this will probably come up later, it will in a couple of slides, but I'm going to go ahead and mention it now. We've invested a lot with wraparound services in Texas with local mental health authorities, and I know for youth that are in the YES program for that 1915C Medicaid program. But if there is a wraparound team that is being used in the community, that team should hold true and should be the same when that youth goes into a residential setting. So that you're not switching gears, that will help with that community integration and continuity. And that you're looking at the staff having 100% competence in skills that really embrace those values and have that respect and compassion and empathy. We were talking the other day, and I know that the Rhode Island team, we were talking about the DREAM team and what are the characteristics of staff, whether they're clinical, frontline, anyone, and it's just having that passion and empathy and kindness, and really looking at that as that being a part of being embedded in your organization, and having multiple program practices that are really clearly spelled out for each value, and sophisticated supervision systems where you're really looking at that. So, for example, and we know that a lot of these things don't happen overnight, but incrementally in small steps. For example, Raquel Hatter she's the CEO of a large residential. After gaining education and awareness at a BBI summit, she went back and implemented multiple improvements, focused on welcoming families as full partners, hiring that senior executive focused on family. Rewrote job descriptions to make sure that family-driven care is embedded in job descriptions of most of, or if not all of her staff, and made supervisors accountable. And actually some even eventually were asked to leave because that is just a part of the transformation process as far as getting on board to not have staff undermine moving forward with this transformation effort. So the board or executive in fully implementing these focus areas, there would be some priority, as I mentioned earlier, on really family search and engage, making sure that youth are connected to someone, a family member, or in the community. And as I spoke about earlier, the wraparound, the child and family teams or wraparound teams, that those are consistent, and that you're really looking at implementing best practice that has evidence behind it, like functional family therapy or multi-systemic therapy. And what we like about those evidence-based practices are that they translate to the family and community. So doing a practice within a residential setting that you get a lot of great outcomes, but that doesn't translate to what's going on with a family and in a community, you may not be getting your bang for the buck there. And just really having clear expectations for all disciplines of staff to work interchangeably from residential and home and community. So one of the things that I know that is always very helpful, and especially depending on the audience you're talking to, certainly funders and decision makers, is data to inform practice. And some of the examples of data that you can look at to help drive how you are doing and how things are going from a leadership standpoint are looking at restraint and seclusion data, achieving permanence for every child, and putting into place for every child a broad community support network, looking at discharges and out-of-home placements. And really, we've talked about this too, looking beyond what we've coined like the honeymoon period 6 months afterwards, but really looking at a year to 2 to 3 years after discharge to see, are we speaking to long-term, sustainable, positive outcomes post-discharge? And the number of hospitalizations, those are some data elements to really look at to see if you're seeing some positive change from being more family-driven in those areas. So the new bar for children, as I mentioned, is 6 months to 3 years post-discharge. That's what the research are telling us. And then the data quality improvement examples with regards to data is the percent of, if residential programs can look at the percent of youth spending time every day with family members and or community engaging in pro-social activities with pro-social peers. That would be a data element to look at, or the number of family members that are met with every week, the percentage of families connected to and a part of family support groups in communities. That again would be another quality improvement example. So for boards and leadership and executive focus to look at fiscal strategies that are supporting working with families, we've talked about this before in another webinar, but too, are some of the resources that you have, and I know one of the barriers or challenges that we hear about a lot are youth that there's miles, they're not placed close to their family. And so looking at, do we have fiscal supports to support Skyping or gas money or getting those families reunited and having time, to look at what they need to do to support post-discharge, offering long-term respite and in-home support. And then, again, as I mentioned earlier, setting those expectations and job descriptions and perhaps in contracts for a minimum percentage of time for staff to be spending in communities with families. And I know some organizations have done some innovative things like renaming positions, so for clinical staff becoming reunification specialists, and I know we've had that term here in Texas as well, but that really emphasizes the focus on permanency and reunification. So here's some other, I'll just let you read this, but here's some other ideas for really ensuring a full family-driven system that executive team members can consider. So also to ensure welcoming and partnering of families, some of the things that you would see is that staff of all disciplines are implementing a variety of family-driven practices. Examples you would see, this was great out of New Zealand, they talked about every staff is the director of first impressions, which, you've heard the statement, you never get a second chance to have a first impression. Well, this would be when families and youth are coming into your organization, everyone's a director of first impressions. Having the being truly family-driven is having families being able to come to the program 24/7 and having warm, comfortable physical environments for families to engage with their child or youth in the program, and then they have access to any part of the program would be, again, an example of strong programs. So thinking about a lot of that, what would your next step be? Some of the examples that you might consider are really looking at language and losing words like home visits. Actually, they're visiting the residential, program. They have a home, so it's really kind of flipped. But looking at some of that language as far as home visits, perhaps utilizing a family focus group to have them help you decide what education offerings would be available for families. And then calling families, and I think about this in school or educational settings, but calling families to share child strengths as opposed to issue areas or challenges that you're facing. And having done a survey most recently and having focus groups with youth will say they want to call their family members or siblings multiple times daily, and I know that that's a challenge, but really looking at how you can help make that happen because they are going to be discharging to theirs, so it's good for individualized approaches to figure out how to make that happen, whether you need to turn off security for photo taking or video taking or whatever things, adaptations that you may need to make. So some other practice would be ensuring that family have dedicated time to talk to frontline staff, that it's not rushed, that they're able to visit so they know how to translate things that are working to their home, and making it a practice to consult with families to seek counsel and engage them in decision making, and then supporting the siblings. We've got some good tools on the BBI website around that. The other thing I want to mention, and I'll go on to the next slide in this context, is that when you're creating opportunities to form memories for families as opposed to having memories for programs and the youth and programs, but really looking at, you perhaps wouldn't have recreation, you'd be looking at recreation for that child within the family and how they're connecting, not necessarily a recreation group from the program. That would be building a memory for the program staff. So you might look at gathering tickets or freebies around the community and use those to offer to families to use with their children with staff support if needed. So it's really just developing close collaboration with clinical expertise in the community too. So that will translate back, into the community for experts in trauma or looking for those supports for substance abuse, domestic violence, or supports in housing, community activities, looking at peer mentors and respite. So with, the knowing that this is what I was mentioning on the strategies from long distance and talking to a family, and of course Texas is a great state, great big old state. And so looking at that challenge for us, I know I was talking to a program in Texas that was saying they really rely and use Skype a lot or FaceTime to have youth be able to meet with their family and see their faces. And so policies for that to support those long distance would be what I mentioned earlier, and that's a few of those written down. But really policies and practices and staff training to encourage to do really whatever it takes to get youth home. It's recommended twice a week at a minimum, and I know that's a challenge for staff that, for youth that are housed miles and miles from their home, but also to help youth get home, not to miss any important family events. If there's a family reunion or, just different family events, that they're not missing out on that. And really developing and licensing community programs in communities for youth to come and develop those strong partnerships that you have. Perhaps the residential program has joint training with community programs, or again, there's that sharing of the joint values. And again, like I said, sharing strengths. And here's some more ideas for policies and practices and staff training to encourage enforcing family-driven care. And I'll just mention a few things of what to be cautious of. And I mentioned the events on residential campus, just really looking at moving special events to be more family-focused and family-centered, and be cautious of having committed, sophisticated clinical supervisors, and, really just look at, is it things that you're doing, is it about the program or is it about the youth and family? And so just a quick mention as I start to wrap up here on youth-guided care. We had a webinar a couple of weeks ago about that, but there's a lot of alignments, but yet differences between family and youth, obviously. Many times youth are becoming of age to be independent and question authority and question their families, and we want to encourage that, and but at the same time families are there to back them up and to be there for them. So interface between youth-guided care and trauma-informed is really focusing on that healing environment, and there's a lot of information and research out on trauma on the brain and body. So that really goes in line with reducing restraint and seclusion as well. So I'm gonna switch on down to these quotes on the next slide. I thought that this was really telling, because I feel like this shit can go with families too. Youth has said, I've never had anyone look at me with possibilities, and that's the lack of that strength-based approach, but families would want to see that as well. And then a quote saying, you need someone to ask you questions, to be interested, to really give you a voice. Families would say the same thing as they're through their journey of, working through these challenges with their youth. And what's the relevance of, is what you're saying, what is the relevance? Is it important to me? Giving choice often, providing mentors, and always listening and being there and showing up and making an impression to give hope, I think, is our goals. So authentic youth and family engagement really happen when youth and family voice are truly valued, and youth and family are used as a resource in the development of themselves, but also in their community, and that you really utilize youth and family as decision makers, and there's an equal partnership and a shared respect and responsibility. And with that, you would bring long-term post-discharge positive change to youth and the families that we're serving. So with that, I'm going to take a breath and offer you these contact information for BBI. Dr. Gary Blau is the branch director for the Child and Adolescent and Family branch at the federal government under SAMHSA, the Substance Abuse Mental Health Services Administration, and he is he's one of our allies and promoter of BBI and best practices within residential programs. Beth Caldwell is the director, and then myself and Kelly is a colleague that we're all working to advance these best practices in BBI. So feel free, if you have any questions and follow-up, to contact myself since I'm here in Texas, and I can certainly help contact you, put you in touch with other people that are on this journey and help you be successful. So with that, I'm going to turn the program over to Carlene McCann and her leadership team. Carlene's the executive director at St. Mary's Home for Children in Rhode Island, and they're at the relatively, we've said this for a while, but at the beginning stages of their transformation journey and have really latched on to the family-driven care piece in their transformation of bringing best practice within St. Mary's. So I'm going to turn it over to Carlene and let her tell you about how things are working from her end. Carlene?
Thank you, Sherri. I'm here with Lisa Conlon-Lewis, Executive Director of the Parent Support Network of Rhode Island, and Patty Olney-Murphy, Clinical Director of St. Mary's. And we're going to start by telling you a little bit about each of our agencies and then move on to the meat of the presentation. St. Mary's Home for Children was founded in 1877, and as many human service agencies was created as an orphanage. Currently, we provide high-end residential treatment services and aftercare services. We also provide hospital step-down or acute residential treatment services, shelter placement, and a number of outpatient services. Our specialty is sexual abuse treatment and trauma, and we are out in the community quite a bit with enhanced outpatient services. We also have just started a couple of new programs. One is working with youth who have been victimized by human trafficking, working out in the community with the youth and their families, and also working with adoptive and foster families to preserve placements for children who have sexual behavior problems. In addition, we also have a special education school where many of our residential children attend, and also folks from or youth and students from outside of our agency who can't be maintained in their public school systems also come to our school. And I'll let Lisa talk about Parent Support Network of Rhode Island.
Good afternoon, everybody. Hi, I'm Lisa Conlon-Lewis, and I'm the director at Parent Support Network of Rhode Island, but probably first and foremost, I'm the parent of once a young man. Now he's actually in his early 30s now, but I was that parent that went through the experience of having a child with, significant mental health challenges who was in and out of being able to be home and in placement. So I understand firsthand what that experience is like, and that's always a requisite at Parent Support Network, that we're a statewide family-run organization, and everybody that's working at our organization is either a parent, peer, youth, young adult who has been through these similar experiences. So our organization started around 1986, so we've had some time to develop and mature. We have a strong team of parent partners who provide peer support services statewide, and we really cut across and have contracting to provide parent peer support across education, special education, children's behavioral health, child welfare, juvenile justice, and have had a strong relationship with our Department of Children, Youth, and Families to have parent partners actually team up in child welfare. So it was a great opportunity to join with St. Mary's because we were already starting to get that work underway for ourselves. We go to meetings with families. We have a toll-free helpline that everybody can call into all the time. We will go to court, we will go to discharge meetings, treatment planning meetings, education-related meetings. We will sit in really where the parent needs us in an effort to help them find their voice. We offer a number of different types of support groups across the state, both for parents. We also have a youth track with Youth Speaking Out. We have a number of social events where we're trying to build positive family and child interaction and community connection. We have educational workshops, including doing evidence-based parenting classes, both individualized and group. And then again, back to the importance of some of what Sherri was saying, is just as much as we build our direct service and peer support, we're also trying to cultivate both family and youth leadership. And so we have ongoing training that helps support our parents to become effective leaders and involved at changing and making and supporting systems to become truly family-driven. And they do that by sitting on different agency advisory boards, state, regional policy boards, committees, advocacy work groups are, really trying to build a system of care that is truly driven, family-driven at all levels. And so that is a lot about who we are, and what you'll hear more about is how we're bringing all of that into St. Mary's partnership with the BBI.
So I'll tell you a little bit about why St. Mary's had decided to look at the BBI framework. We had actually started doing a little bit of research around residential outcomes, and we weren't seeing a lot of really positive outcomes in the literature. And we realized it just anecdotally from watching our youth who are in care start to make gains here, begin to plateau, and then start to decline. And we would see this over and over again, and really wanted to know what we could do differently to actually help our youth have better outcomes when they left us. So while we were doing the research, we stumbled upon the BBI website and started reading their materials. And once we did, we recognized what BBI had already learned was really what made a whole lot of sense for the way residential should be done moving forward. So as we were doing residential, our instincts were telling us that we needed to be much more involved with our youth's families. And while we felt we were doing a decent job at engaging families, I think when we really got down to it and thought more about it, we recognized that we weren't as terrific at it as we had hoped. So we learned that we really did need to be much more flexible. For many years, we thought parents were supposed to just come out to the agency and meet with our clinician once a week and visit with their child once a week. And that was not really working so well. And when you're expecting people who can barely meet their basic needs to be here at a scheduled time and maybe bringing 3 or 4 other children in tow, it just wasn't very realistic. So we recognized that we needed to be flexible and go out into the community and work with families in the community. And so the other thing that we were seeing is that we, as an agency that's been here for a while, we've seen the same youth cycling through our programs. And that could be pretty disheartening because obviously you want to see the kids that you're serving succeed. So it was time and again we'd see youth come through. They may come through as a young child at 8 years old, and then they would bounce back in here maybe when they were 11 or 12. And things were worse at that point. So we recognized that permanency just wasn't there for a certain cohort of the children that we served. And when you think about that, if there's no permanency, how can these kids begin to heal from the experiences that they've had and the trauma that they've experienced? So that was another reason why BBI looked like a framework that would work really well for the families that we were serving and the youth that we were serving. As many residential programs, we unfortunately had that mindset that, we know best, and the parents maybe don't know quite as much as we do about how to raise their own children, and we had to get over that. And that was a really negative mindset that was not at all helpful. And so we had to work on our culture around the fact that parents are not the enemy here. They are our partners. And many of the youth we served were here for much too long. Before we began BBI, our average length of stay was between 14 and 15 months, and some youth were here for 3 and 4 years. And, that's basically you're just institutionalizing these youth and not giving them those normal experiences that they need. So we could see that we did know that long-term residential treatment was not working well. So, but we also always recognized that residential is part of the continuum, but as an intervention and not as a destination, as some of our BBI partners learned before we did. For us, this was a natural evolution for our agency because about 10 years ago we introduced the relational model of care here, and that was out of Holston Children's Home. We learned quite a bit from them, and as we implemented that, we were also weaving in trauma-informed care. We did away with levels and points, and it was very clear to us that with those kinds of systems, we were really making kids good residential clients, but not really preparing them well for life outside of residential. And for me, looking at BBI, I love the fact that it was a framework and it wasn't prescriptive, but there were values and principles that we could get on board with. And so the thing that the framework allowed was a lot of creativity and flexibility. And for folks that don't like to be told what to do, it was a really nice way to bring a new framework and some fresh ideas into an agency like ours. So in terms of laying the foundation for BBI, we had our leadership here begin reading some of the BBI materials, and we shared with key members of the residential team. One of the most energizing things that we did as an agency was go to Children's Village in Dobbs Ferry, New York, and we spent a day there with that team, who were as gracious as can be. They were able to spend the day with us talking about their journey, what they were doing, the lessons learned, successes, challenges, and best practice. When our team left there was so much enthusiasm on the drive back home. I certainly got the sense that this was definitely the way we were going as an agency. It's led to a lot of internal conversation here at the agency, created a little bit of buzz. People wanted to know more about BBI and what that was all about. We brought BBI training out to the agency. Beth Caldwell came out and did some training to solidify the agency's direction. So after we read the materials, we visited Children's Village, we had Beth out to do the training. It was kind of a no-brainer at that point that this was where we were going. After all that, we created a program and logic model, and which would later serve as a blueprint for implementation of the framework. And one of the things that we knew we needed to do if we were going to be successful with this endeavor would be to partner with the Parent Support Network of Rhode Island. It meant reaching out for parent support partners, It was certainly a necessary and welcome component of the success of the framework, and is helping with culture change here at the agency. You'll learn a lot more about the role of the parent partner when Lisa Conlon-Lewis speaks. One thing that I sometimes forget to mention, which is key about laying the foundation, is that we did some education for our board of directors to make sure that they understood how transformational the framework is, and to get them behind our new endeavor. So as we were moving forward with building bridges, we really needed to solidify this at the agency and make the commitment to it. So I know that Sherri mentioned having this become a part of your strategic plan, and for us, BBI is a significant component of our strategic plan. It meant family engagement and family-centered practice objectives and activities are featured prominently in year 1 of the plan, and youth voice and choice and youth-guided care with associated objectives are the focus of year 2. Our policies and procedures, which we review every 2 years, we are working, every time we're reviewing them, we're working on including language reflective of the BBI philosophy. Our job descriptions, actually in the position summary of our job descriptions, we have a line or two that ensures adherence to BBI values and principles. We have a parent support partner embedded at the agency and parent support network providing a number of useful services to our families and our kids, and actually our staff, to assist in the cultures. They assist in culture change and help families feel welcome and comfortable. And then the other thing that we did here was we added family liaison positions. Each one of our treatment units has an individual who serves as a go-between between residential and home, and my guess is that Patty Only Murphy might speak to that when she talks about some of the other work that we're doing. And ongoing training and support. Lisa Conlon-Lewis does some training for us to help our staff understand the importance of family-centered practice, a lot of trauma-informed care training here, trauma in the brain training. So we do quite a bit of training so that our staff truly understand the needs of our youth and families. So at this time, I'm going to turn it over to Lisa Conlon-Lewis, who will talk about the parent support role and family-driven care.
Great, thank you, Carlene. So, Sherri had already introduced the definition of family-driven care, so I'm not going to read it out loud to you again. But I think what's really important is when you look at the paradigm of shift of the practice, as Carlene had mentioned, family-centered practice, that, gets families even looking at their voice and choice and their meaningful participation in the process. And so a lot of times you're working on family-centered care, and System of Care has really worked hard on this definition of family-driven care. But for a family who's coming in who's very many times overwhelmed and heavy stressed, trying to care for their child and many times meeting some of their own self-care or building their own protective capacity to better care for their children, it can feel very overwhelmed, never mind to say, oh, I want to sit on a policy board now and make system change. We have to really meet them where they're at. And again, our goal is that they're going to become strong enough in their own needs and their child's needs, and beginning to take that leadership, take that charge, have a voice, begin to make decisions, begin to question things, participate. For some of our families, that many times the parents themselves are working on their own mental health and or substance use recovery. And so there's lots of levels of this. There can also be 1 or 2 children that could be at St. Mary's, but then there could be 3 other children that's part of the family, and they're in at home and or in other various placements. So it is really important to meet the family where they're at, to gather their voice, to begin to help them feel a level of confidence and empowerment to making decisions hand in hand, to hear others' points of views, to begin to build a two-way communication that's respectful. Sometimes families are very angry, and sometimes they don't feel that they're part of the decision-making. And sometimes that has already happened before they got to St. Mary's. So if people are familiar, in child welfare and placement decisions, a family could be arriving here at St. Mary's, and there wasn't a lot of decision-making part on that parent before they got here. So I think as we talk about the role of the parent partner going forward, you start to begin to change that paradigm as they enter the door of St. Mary's if it hasn't happened beforehand. So could you help me with the next slide? Thank you. So in the parent partner role in a general way, we're promoting engagement of parents to fully participate in their youth treatment, and that sometimes is new. They're not used to being put in the driver's seat and being asked to make a lot of the decisions in that process, and you have to meet them where they are and give them and support them with the tools to really being able to feel they can do that successfully. And they are to feel involved in everyday decision-making for their youth in care. And that could be even how treatment is taking place here at St. Mary's, and giving recommendations and support, and then how that treatment starts to change from just St. Mary's based to community based to home based to hopefully successful transition more quickly. And we do a lot to provide ongoing support and education opportunities. So we're really building a lot of what we have been doing statewide and community-based within Parent Support Network, and bringing that into St. Mary's, and as we say, taking down the walls to really begin to then bring that broader back out, starting at St. Mary's, and as we can move with the youth and the family to bring them more back towards home and community. We do a lot of work with the parents, especially around their own self-care and nurturing parenting skills. So we do the evidence-based nurturing parenting program, and we do that both individualized in groups, and we really work with families to move along where their needs are to build their protective capacity and to feel really strong about themselves. Many times if you have not had a sense of being nurtured yourself, it's really hard to nurture. And so we have to do a lot of work with the parents themselves before they can really feel they can take the lead with their children around those needs. And then, there are different family backgrounds coming in. So I think that's much more challenging and more individualized, intensive work if the parent has come in more through an abuse and neglect situation and they're working on protective capacity needs, versus another parent gets more involved because they have a child with serious emotional disturbance, but that parent is very strong and confident in their parenting skills, but they have, and this was more my situation, I had 4 children I was raising. Of those 4, 3, my good training and parenting skills worked, and there was that one child that had really serious mental health needs that it was going to take a big support team to help me and to make that work. And so, again, there's lots of communication working many different ways between the parents, St. Mary's, our Department of Children, Youth, and Families, which is child welfare, and pulling in lots of community-based providers and natural support. Some of the activities we do is we knew right from the beginning that we did not want to hire a new parent partner that had not had a length of experience with our own parent organization or St. Mary's. So right from the beginning, we took one of our senior parent leader staff and we put them in the helm of working in partnership with St. Mary's. And then right from the beginning, we were embraced at the executive and clinical leadership team level. And there was definitely, and it continues to be, it just gets stronger every day, a shared decision-making approach in the program model and implementation. And I would say our senior parent partner works hand in hand with executive leadership and lead clinical, and Patty will probably speak more to that, but it's a strong partnership at all levels. Our parent partner participates right at the admission, so that's right at day one, and we're engaging that parent to help them feel comfortable. That's a hard step to say, oh, I'm coming, but my child is staying, and how am I going to feel comfortable with this? And of course, there's tears and fears and anxiousness, and our job is to really engage them while they're here, get to know them, make sure that we are a connection to them at any point in time in need, and begin to help them answer all their questions, build communication with the support staff here at St. Mary's. Also, we're helping to describe with the parent really what to expect with the Building Bridges initiative and how that relationship between the parent, the youth, and St. Mary's staff is going to work. We've worked together with St. Mary's to update and support the parent handbook. We work back and forth reviewing and communicating all levels with staff here. We're quick to jump in if a parent is not feeling someone is responsive. We jump right in and we have communication with that, and everybody gets right on top of it, and they embrace that family, and there's never in our part, it's never felt like a finger pointing or a blaming. It's like, what can we do to better help this family? And sometimes our families, because of those anxiousness or fears, get scared, they shut down, they're afraid to communicate, and so we're trying to encourage them to build that even more. Our parent partner works directly with the clinical team to support both the parents and other family members involved to really share and engage. Because we have that lived experience and can do a level of self-disclosure, having had similar experiences, we're able to get them to really do a strong strengths, needs, cultural discovery, and really share that information that maybe others haven't been able to gather, but we're able to learn, and they're usually very open to sharing with us, and then we help St. Mary's to gather that same level of information and the parent to feel comfortable sharing that type of information with St. Mary's. So I think another exciting thing is, as Sherri talked about, that open, ongoing communication back and forth, we are definitely having an impact on families and their children calling back and forth and feeling more comfortable, and we try to help facilitate that as much as possible. And however we can really increase visitation, whether that's to St. Mary's or a home back to visiting back at home, we're doing a lot of work to help connect that. St. Mary's is great around transportation, but also our parent partners know if a family doesn't have a level of trust to utilize that, we will use that as an opportunity to give them a ride and engage. We help them with their own treatment planning and review meetings, so we're right there alongside them. We've actually been, I think, back to changing some of the culture, great role models in helping taking the lead around facilitation in meetings, especially between Department of Children, Youth, and Families and Child Welfare and the treatment planning at St. Mary's, and bringing communication around some of those shared goals. So we're able to really help them prep before meetings, help them feel that they can really raise their voice and participate in the meetings, and then also we help debrief and make sure that we're helping them towards their goals and action steps. And again, we're working on their self-care. I'm excited to say right in the other room as we're doing this presentation, we have 7 family members working with 2 of our staff to do the nurturing parenting classes, and we have a great empowerment model of how we've adapted those classes to where many of them then become graduates and co-supporters to new parents going through that process. And we're, as parent partners, we're working with our family members to help them to attend ongoing family and community events here at St. Mary's and in the community. So that's really nice. So even though the families are here today doing the parenting class at St. Mary's, I got to meet a whole bunch, almost all 7 of them last week because they were coming in one-on-one to do the assessment and meeting at Parent Support Network. So now they were already getting a connection. They were already meeting their support organization beyond the walls of St. Mary's and knowing that that's a place that they can have a long-term relationship with even after their child transitions. And we're trying to make sure as much as we're coming here and working as a team on family nights that we're also trying to plan some of those same types of activities out in the community. We're working with parents to participate in, as I said, around building their protective capacity skills in areas, and we do a lot of that through the nurturing parenting. And some of our parents are ready for group, but some level of individualized support, so we don't want to ever take away from them being part of a group experience because that is great learning and support in itself, but they may need the parent partner to do both a few lessons and follow-up to reinforce what was shared through the group and to help them practice that. We jump in support around supervised visits and non-supervised visits to make sure and support that parents are able to practice their skills that they're learning, especially if there is child welfare, and helping to them take the steps to have that unsupervised and more connected relationship with their child. We are also helping them to celebrate every accomplishment. And so it is really important to have lots of little celebrations, whether it's a little dinner celebration here or giving flowers to a certain youth or family member. We try to really celebrate everything that is being accomplished. And then we're very much working on the whole transition. So when a family is transitioning with their youth from being more here on a consistent basis to now going back to living at home, we're right involved over a 6-month process to really make sure there is a strong, successful transition to home, and that as they close out through St. Mary's and even hopefully through the Department of Children, Youth, and Families, they're still part of a strong support network. And with the leadership in that, we hope that even some of those family leaders may become employees with our organizations, parent leaders with others, and sitting on policy boards. So, so the last thing that I'll share and turn it over to Patty is we have definitely been supporting and changing the work culture here at St. Mary's. And again, by positioning ourselves sitting right at the level executive and clinical leadership, we're really promoting that positive change. I think that, we're very fortunate too that our senior parent partner, Brenda Alejo, is one of the most nurturing people you can find and see, and she's a team builder. So she actually will spend time across all the units, getting to know every staff person, feeling, really we're trying to create a sense of home, not a sense of a institutional setting. We're trying to really make it feel like we're a big extended family and all working together with the families. So we're here many different times. It could be evenings, it could be weekends. We try to make ourselves as flexible as we can be. And again, a lot of times, just like any family, there's a lot more family connection that happens nights and weekends than during the day because of school and employment for parents. So we're trying to really work together and bringing that sense of home and community. And then we're also, as Colleen said, we're doing a lot of the co-training and leading, and what's been nice as we've been coming in and co-leading some of the training and development around BBI, is it's been inclusive of anybody that's part of St. Mary's. So there's cooks, there's janitorial. If you have a role at St. Mary's, you're part of BBI, and everybody has an expectation. So everybody should be checking in and smiling, having a connection with the youth, feeling comfortable, welcoming. The family walks through the door of St. Mary's. Everybody should welcome that family in. So I'm going to turn it over to Patty now.
Hi, this is Patty Only Murphy, and last but not least, I'm happy to talk to you about leading with family engagement. I wanted to start with the intake and admissions process and making it family friendly. For us at St. Mary's, we changed where we meet with families, so it's really about the venue of the family's choice. We've met families at their home, in the community. If their child is inpatient in a psychiatric hospital, we'll meet the family up at the psychiatric hospital. We've met a parent at a homeless shelter, and it's really wherever the family is comfortable. If they want to come to St. Mary's Home for Children, they're also obviously welcome here. We start with high levels of empathy with families, so really using interpersonal strategies to engage with families. We do a lot of empathy and validation, inquiring about cultural and religious beliefs with families, expressing hope for the future. We attempt to validate and reach for feelings. We attempt to understand the caregiver's experience and the family's experience from their perspective. We offer a lot of psychoeducation in terms of giving hope about trauma and children and how they can make gains, and family treatment and best practices with family and child treatment to give hope. And many times our parents are also trauma survivors, so when you're doing the validation and psychoed with families, you're also indirectly doing that for the parent. Family is in charge of decision-making regarding placement, and I want to mention a caveat with that. So this required a lot of work on my part and also other employees' parts here at St. Mary's in advocating with DCYF for this. In the past, really business was your child is going to be placed at St. Mary's Home for Children. This is your child's placement. And even now we have to remind DCYF at times that prior to a child's placement, we do have to engage with the parent. We do have to provide the parent with a tour. We have to introduce the family to the Building Bridges initiative and the type of clinical work the family can expect and the type of milieu that their child will be in, and then tell the family that they're really in charge of making a decision, and ask the family if they've toured other agencies, if they've had the opportunity to meet other programs. And if they haven't, we should advocate that they should at least take a look at a few more programs for their child before they make a decision, because this is a big decision for a family to make. The advocacy piece in that really, I think, is with the residential provider and your good relationship that you have with DCYF administration and workers to really present that families really need to be in charge of making the decision, not DCYF and not St. Mary's. That was a bit of a hard sell, but I think DCYF has really onboarded with that philosophy, I think thanks to the people in charge of sending referrals and also the workers. The tour of the agency involves not just staff at the house. The tour is the grand tour. We introduce parents to the kitchen. In fact, we always invite parents to have lunch here with us, with the staff, or dinner, or coffee, or whatever time of day it is. We introduce the parents to the maintenance staff, and we do that for a reason, because if the parents have a concern, we want them to contact, the maintenance department and know who they're talking to if they have a concern about the maintenance of a building or the grounds. We introduce the families to the nursing, teachers, administration, finance, the secretaries, the campus supervisors. We really want the families to know who they're talking to when they're on the phone and who they can go to with various concerns. The house staff members meet with family to discuss activities, routine, allowance, our transportation grant, our community grant, cultural or religious preferences of the family, family activities or traditions we should be aware of, sports teams their child may be on, and really help families feel warm and comfortable and that they're in charge, and we are seeking their feedback and their knowledge in helping to plan for their child when they're here. Let's see. Okay. Beyond family engagement to busting barriers, St. Mary's, we attempt to do daily contact with families by phone, home pass, or family time on campus. On occasion, we have parents that are incarcerated in prison, and St. Mary's will arrange with the prison, unless it's contraindicated, for the child to visit with their parent at the prison at least once a week. Right now, we have a youth that is visiting a federal prison every Monday to see her dad. Transportation is provided when it's a barrier. Our development director was able to get us a significant grant to use, and we've partnered with a cab company, and we are able to provide cab service to parents to get here to St. Mary's for visits or IEP meetings, or to get them here to pick their child up and then bring their child home. We also have a parent support partner, family liaisons, and clinicians that are out of ratio that are also willing to pick parents up when needed. We have campus-wide community nights. We try to lose the term family nights, but it's on here. We use our interns to coordinate family nights on campus. We're going to be looking to do more off-campus community nights. Our interns work in conjunction with the parent support partner. They coordinate the events to make them family-friendly and at a time when most families can attend. We send written invitations, and we make several phone calls prior to the campus-wide community night to see who needs transportation, who's coming, and if there's a barrier to them coming, how we can bust that barrier for the family or caregiver or mentor to be there. Community activities with families, we do have a very generous community activity grant that we received from several foundations due to our development director that we use with families to fund kids' dance lessons, snowboarding, snow tubing, going to museums, yoga, sibling activities, and sometimes the campus-wide community nights. The treatment plans used to really focus on the child that was here, and we don't do that anymore. We focus our concerns where they are, and they may include parent, family, and sibling goals, and not an individual goal for a child. So we're trying to constantly assess needs and where the challenges are to address them so the child can go home and have a shorter length of stay. Education to families, this is done in a number of ways. So we do this at intake, and we also educate the Office of the Child Advocate, CASA, which is the Court-Appointed Special Advocate, judges, and DCYF about shorter lengths of stay, and we do that verbally, we do that in court, we do that through court letters, we do that through treatment team meetings, we do that as often as possible to inform providers and family members about the detriment of a child staying in residential treatment for too long. Interventions to address interpersonal and practical barriers. In terms of interpersonal barriers, we've had some parents that are deaf and hearing impaired. We have a number of parents that are oftentimes very triggered and untreated trauma survivors and are in need of a lot of support. So we try to build those into meetings to assist the parent to be productive in the meeting and helpful and focused so we can help their family move faster through the residential treatment system. Practical barriers, again, we focus a lot on case management, referring people for basic needs, food pantries, heating assistance, HUD, housing assistance, transportation. If a family has no daycare, we tell them, bring your children. We've had a family here that had 7 siblings here running around and a bunch of us chasing them. And we have to do what we have to do to make this work for our kids and families. Again, the high level of empathy and validation. I do want to talk a little bit about the strategies that we use to develop a therapeutic alliance with families. We constantly assess where parents and kids are at. We work with parents where they are, and we're very careful. We have all been trained in trauma-focused cognitive behavioral therapy, and that is very heavy on parent involvement. So it's working with the child on their trauma, but it's also working with their parent on their child's trauma, and sometimes indirectly working with the parent, or directly working with their parent on trauma. Okay. Aftercare. So we're still learning and growing in this area. This has not been easy in terms of policy and procedure. We say discharge planning begins at admission, and we mean that. The day of admission, we talk about 3 to 6 months is the maximum benefit. Research shows that 3 to 6 months is where your child is going to get the most benefit from a high-end intervention like residential treatment. Short-term treatment is the best for your child. Anything longer could possibly be detrimental to your child. So we want to work very hard within the first 6 months of your child's admission to get your child home. So that begins at admission. Some members of the team stay involved in aftercare. So Carlene talked about family liaisons. They are full-time staff that are out of ratio, that work in the milieu, in the community, and in a family's home. And they provide home-based services after a child is discharged. We have also hired a clinician who has extensive training in trauma, and she also provides the aftercare, and Brenda Alejo, our parent support partner, provides aftercare as well. The tricky part where we're growing is that we don't have a formula just yet about how to work out the 6 months of aftercare. Sometimes it's just the clinician, sometimes it's just the parent support partner that provides the aftercare, sometimes it's the family liaison and the parent support partner. It's really, at this point, who the family has connected with, who the family and child trust, and who they really want in their home from St. Mary's. In addition to us being in the home, we obviously provide an aftercare plan that is in the best interest of the family and that the family agreed upon. And sometimes the Department of Children, Youth, and Families put in non-negotiables, and those are fine too, and those are treatment plans and that are mandated that the family participate in. Let's see. Some of the services we provide in aftercare, it's home-based, it's community-based, it's parent advocacy, case management, individual, family, couple, sibling counseling, and a whole mix of that type of service. And I wanted to talk to you about a few of our successes here, and it's pretty significant. The first is a young boy and his mom who suffered from OCD and agoraphobia, and I'll tell you how we found that out. This was our very first Building Bridges Initiative family. I was sitting in Carlene's office with the Parent Support Network and Carlene, and we were talking about this one mom who the staff were saying she never comes and she's not interested in her son. And the parent support partner and I decided to go out to her home on a Saturday. The mom was agreeable to that, and we went out to the home and found that the mom had pretty severe OCD and agoraphobia and a very significant trauma history herself. She wanted to come to St. Mary's, she said, but she was too afraid to leave the home, and she didn't like to touch things, and she was very preoccupied with these things. So the parent support partner is really the one that took the lead in getting mom here through transportation, and unfortunately the parent support partner, I think, had to go each way with this mom in the cab. She had to drive up to mom, get in the cab with mom, drive here, and so it was a pretty lengthy process. But I'll tell you, in 4 to 5 months, we had mom out of the home, mom shaking hands with people, mom hugging people. We had a adult enhanced outpatient services in her home. We had psychiatry for this mom, and so her mental health improved pretty significantly. We were able to get this child home, not with mom, but with dad, but mom and dad are divorced, and they were able to co-parent. Our second girl, this is pretty interesting. She is a girl who kept going AWOL and eloping from St. Mary's, and she kept going to her dad's home, and we found out this through her. Her dad's rights had been terminated, and we begged DCYF to please get in touch with dad, please meet him, because this child, who is a teenager, keeps running from St. Mary's and going to his home. So DCYF did do that with dad, met him, worked with him somewhat, and St. Mary's parent support partner, clinician, and family liaison were able to enroll dad in our Nurturing Parents program here at St. Mary's. Dad has not missed a campus-wide community night or a house family night. Dad and our parent support partner was also able to find an attorney with a big heart who is doing pro bono work to overturn the dad's termination of parental rights so dad can have his rights back and reunify with his daughter. So that is a big success. We have a teen girl here that has significant self-injurious behavior, and I wanted to talk about this because she's been 109 days self-injurious free, and she's been 109 days safe, and she is going home with her mom and dad in June. And I'm going to tell you, this is the recipe. If you have to make a recipe for healing, this is it. The ingredients are one good trauma clinician, one good parent support partner, one very interested milieu staff, someone who takes an interest in the child, who is interested in implementing coping skills, interested in learning what that child is good at, what he or she likes, and focusing and really mentoring that child, and then one interested parent. And those four ingredients really changed this child's symptoms and reduced them to the point now where she is going to be going home. So I thank you, and that's all I have.
And thank you. If you want to put their last slide up on St. Mary's, I think has some contact information. Thank you. This is Sherri, and thank you so much for your presentation, Carlene, Lisa, and Patty. Loved all the tidbits of great information. I love the recipe at the end for the makings for a good dream team and a successful intervention. I wanted to encourage, if anyone has questions, to use the chat box and write a question, and I want to go ahead and pose one to the St. Mary's team. Amanda asked about what are some effective ways to help engage with your welfare system when you're looking for families, especially if the powers to be has said that family is not an appropriate placement. So how do you work with your child placing agency at the state as far as looking for family search and engage, who's taking what role? Could someone speak to that, please?
Hi, this is Patty Murphy, and I think Lisa also wants to answer. I'm going to maybe give a very oversimplistic answer, but the dad that the child was going AWOL to this dad had a pretty significant history with the Department for Children, Youth, and Families in terms of neglect and domestic violence, and his own juvenile and young adult record. Our advocacy is that people change over time, and we had them look at the number of years that had passed since dad was involved in those kinds of things. We convinced DCYF to give dad a chance to let him do substance abuse screens to prove himself, to attend domestic violence classes, and also to attend the Nurturing Parents program. So it was really advocating based on a person being a young parent and making mistakes, and talking about how his frontal lobe was not developed at that time that he was doing those things, and that science. And I think DCYF is in a place now where they're willing to do that, and because our resources in foster families are so limited, they're really looking at helping parents to get custody back of their children, I think. So it was a positive system, and also I think our advocacy.
And I would just add that I think the role of the parent partner helps facilitate the communication where had some of these parents had received early on child-centered, family-centered practice and or family-driven practice in their first experiences with child welfare in the Department of Children, Youth, and Families, they would have probably not had their rights terminated. And I think that the parent partner really adds a level of helping to bridge the communication and the trust and the sincerity and the hard feelings and experiences that a person is going through that has to come out. So I think we're the ones that I think are helping both the department, like child welfare workers or the clinical people here at St. Mary's and elsewhere, to really begin to hear the story behind the parents to where they are. So yes, at one point they may have been making bad decisions or didn't have the protective capacities they need. Sometimes there's multi-generations of child welfare involvement within a family and or past use of substance use and or their own mental health challenges, as you heard Patty share the work that we're making through those experiences. But getting people to hear and listen and slow the process down with others not making those decisions already is, I think, how it's really shifting to getting good placement decisions, good steps and strategies. But I think it makes a big difference when the parent themselves is heard and helping to make those decisions.
Thank you, Lisa. And I think good communication between an agency that really is very overtaxed and seeing what pieces that, the program can do, and especially with the family liaison positions that you spoke about that help with transition to home would be great. I'm going to go ahead, and I know that there was another question about the ratio of family liaisons to youth, but I heard different titles for family partners and family liaisons. So if we can get a quick answer to that, we'll close up. And if anyone has any questions, here's contact information on the screen, and as well as the files that are downloadable in your lower left-hand, the file share box. There's contact information as well as on the overview statement. So I'll let someone answer that question about family liaisons, how many, if there's a certain ratio that you're looking at.
So it's a team approach. So for every unit, there's a family liaison and a parent partner and a clinical team that wraps around. And so what's important in the role of the family liaison, they aren't a parent, but they're a strong clinical support team person whose role is really focused on the engagement between youth and family and making sure that youth is getting good, positive youth experience, and their needs and strengths and assets are driving what they need to do to be strong. And so they're bridging and ensuring the new BBI practice of home and community, but primary, making sure that those connections happen and that takes place. And it's driven more from the perspective of the youth who is here, to where the parent partner is really there is going to jump in definitely and build relationships with the youth while they're here, but their primary role is to the parent, the primary caregiver, and helping and ensuring their full involvement. So of course that's going to take really good work hand in hand between the family liaison and the parent partner, and the clinical team members that are also a part of that unit are working and able to actually do much deeper clinical work with both the youth and the family, because they have these other support positions taking on those other responsibilities.
Thank you so much, Lisa. With that, I'm going to turn it over to Lillian.
Thank you, everyone. I just want to say thank you to Sherri, Carlene, Patricia, and Lisa for presenting today, and for sharing your wealth of expertise with the Texas Residential Treatment Centers. I know that we will be referring to these PowerPoints, and also some of us will probably be reaching out to St. Mary's Home for Children to have additional questions answered. I greatly appreciate your participation today in today's webinar. And to our participants, thank you for participating today and for providing questions. And if you have any questions, you can feel free to contact me and the Texas System of Care team, as well as Sherri and St. Mary's Home for Children. As you close out the webinar, please complete the evaluation, as is very helpful for us in planning future webinars and for our improvement process. So thank you very much, everyone, and have a